So again, welcome everybody to the Fall 2021 Faculty Forum. We're really happy to have two wonderful presenters here with us. And I will give a brief introduction of these two presenters. So we have Dr. Jeremy McBride here with us. Dr. McBride was born in West Jordan. He received a Bachelor's of Science degree in micro and molecular biology from Brigham Young University. He was a research intern at the Edwin Steele Lab for cancer biology at Massachusetts General Hospital. He graduated from Johns Hopkins University Medical School and completed both a diagnostic radiology residency and a fellowship in vascular and interventional radiology at Mayo Clinic in Rochester, Minnesota. He has been employed at Mayo Health System of Clare for the past 8 years. He's married to Dina McBride and has 6 wonderful children. Our second presenter is Dr. Liz Glogowski on campus. She is an associate professor in the Department of Material Science and Biomedical Engineering. Her research program with undergraduates is focused on synthesizing and characterizing polymers and other soft matter for applications ranging from architectural coatings to injectable biologic forms, which we will be hearing today. She completed her Bachelor's of Science degree in chemistry at Carnegie Mellon University, a PhD in polymer science and engineering at the University of Massachusetts at Amherst, and a postdoctoral research position at the University of Illinois at Urbana-Champaign before beginning her independent career here on campus at UW Clare. So thank you very much to both of our presenters. Really happy to have you here. And the forum is now yours.
Thank you. We appreciate the opportunity to be here today. Regret that we can't be in person. I have to be at the hospital for call purposes, but I'd like to start out by providing some context for our innovation so you can understand the problem that we're trying to address and what the benefits may be. Go ahead to the next slide. Oh, here's our team. So you've heard about Dr. Glogowski and I, and we have some undergraduates that are part of the biomed program. And you'll see some of the results of their work. These are Kira and Marshall, who are currently working with us. There have been a couple other students who are involved in some of the early research that have been involved as well. Next slide. So I'm an interventional radiologist and I do image-guided procedures. One of the techniques is percutaneous ablation, where we use specialized needles under image guidance, either with CAT scan or ultrasound, in order to ablate tissue. We can use either microwave probes that have a microwave intended to create heat and ablate or destroy tissue that way, or we can use a cryoprobe that uses extreme cold to create a zone of decreased temperature in order to kill tissue as well. So the idea being is that we put these probes or needles through the skin and into tumor, activate them, and kill tumors without having to have a large surgery. Next slide, please. Typically, this would be in the kidney. We also do it in the liver, can also be done in the lung or in the bone. But as you can imagine, we need to get the probe down to where the tumor is. Here you can see an image of a kidney, and there you can see the white line, which represents a cryoprobe that's been placed into a tumor in the middle of the kidney. We can place one or more probes into the tumor in order to get a zone of ablation energy in order to completely kill the tumor. But of course, we want to limit how much tissue gets destroyed because we want to preserve function of the kidney, and we certainly don't want to injure any vital structures. So there's some tension there and balance. Part of this is just by the type of probe we use, the energy we use, and the number of probes we place. But sometimes we need, for example, the kidney to be away from other structures that we don't want to injure. So sometimes we'll place patients on their side. In this example, we have a single CAT scan with the patient lying on their side. You can see you can see one of the vertebral bodies in the spine, and as I mentioned, that probe through the tumor. There's also a dark area around the probe, which represents low density frozen tissue and the ablation zone with this cryo probe. Next slide, please. Sometimes patient positioning is not adequate to get the right trajectory for needle placement or to allow sufficient space between the target tumor and vital or important tissues or structures. When that's the case, the most common technique employed to create some space or increase safety is called hydrodissection. The CAT scan under the hydrodissection subtitle shows, I'd use a pointer if I could, but I'll just try to describe it. The brighter white line is going through the tumor that's part of the kidney. You can see another white line coming from the middle of the screen between two ribs with the tip of it intersecting the probe. Through that, I injected some fluid. Now, by injecting fluid, what it does is it creates a buffer. It creates physical space by pushing away the colon in this case. The colon is that black kind of ovoid shape, but also by creating some thermal insulation by pushing that fluid there. In this case, the fluid was able to create a buffer, and I was able to use 3 probes, create some microwave ablation of the tumor and completely kill the tumor and preserve renal function. However, water flows downhill and takes the path of least resistance. So sometimes when we inject right where we want to, the fluid will accumulate elsewhere and doesn't create a buffer or physically push or displace the important tissues or organs out of the way. The second one, under the pneumodissection subtitle, shows kind of the other end of the spectrum, where we inject gas, which of course will rise and be anti-dependent, as we say, kind of the opposite of the water going into the most dependent or lowest part in the body cavity. So this picture represents, you can see 2 white lines. Again, I pointed out with the pointer, if I could, that are entering a large tumor in the lung. There's a crescentic shaped dark area. That's the gas that we've injected to create space between the ribs and chest wall and the area of the tumor that we are ablating. In this case, to avoid injury to nerves and chest wall structures that would be painful. Next slide. As I'd mentioned, this technique doesn't always work as we'd like it to, despite positioning and injection of fluid for hydrodissection. It can be suboptimal or just outright ineffective. On the right side of the screen, you can see that white line coming down from the edge of the patient in this CAT scan. That larger gray area is the liver, and there's a tumor in there that has a vague white spherical shape. I've injected a couple hundred cc's of fluid through that white tube in order to create some space between the liver and the ribs. You can see on the left side of the slide a vague kind of light gray crescentic shape between the liver and the ribs. And that's the fluid. It didn't go where I injected it. Rather, it went higher up in the liver and rested under the diaphragm. So in this case, it did not provide any thermal protection. We still were able to kill the tumor, but he had some pain for several weeks because of injury to nerves in his chest wall. And this exemplifies this the inefficiencies or inadequacy of hydrodissection at times. Next slide. So when I was finishing my training at Mayo Rochester, I was working with a mentor and we were doing some ablations. And we were discussing this same problem of the hydrodissection not being ideal. And we discussed what might be the ideal agent. We discussed that a gel or a foam could potentially be more of an ideal agent, something that had body or stiffness, so that when we injected it, it would stay more or less where we injected it, but have enough body or stiffness to displace tissues or organs and create some space. It would be stable enough to allow us to do a procedure over 1 to 2 hours, and also be stable enough that when exposed to either cryo energy or microwave energy, that it would not rapidly denature. Of course, we'd want it to be not so stable that it was permanent. We wouldn't want to inject fix-a-flat or some plastic polymer into a patient. We want it to be biocompatible. Ideally something that over time would degrade and just be absorbed naturally from the body without any toxic effects. And thirdly, if we synthesize a new polymer or a new molecule, there'd be extensive and likely prohibitive hurdles to jump in order to have application of this new molecule in patients due to FDA approval. As we discussed this, I had an idea of a way that we might, something that we may investigate to approximate a dissection agent like this, and pursued it briefly during the end of my fellowship. I then took the job here, and lack of bandwidth and particularly lack of resources as well led to this sitting on my desk for 6 years. You can go to the next slide, Liz. At that time, I heard about a collaborative grant that Mayo and UW-Eau Claire were starting. And I approached the material science department, where I got in touch with Dr. Gliglowski, and we began our collaboration. So I will pass the time to her so she can discuss some of the research that she and the students have produced.
Great, thank you. So yeah, as Dr. McBride outlined, he approached us with this idea, and with my background in polymer science and soft materials, it was just a great fit, right? This idea to produce a material that would be used in a clinical application. And then what we do here at UWEC with the undergraduate researchers is do all the materials testing. And so we're creating these foams, optimizing the foams, testing the stability and stiffness of the foams over time, and as well as other testing that we'll see if we have time to talk about. Okay. All right, so we can't talk too much about the details of the materials that go into the foams because we're actually in the middle of the patent process right now, but you can give a general overview and emphasize what the goals of our research have been. And so based on the application, right, there are certain design requirements that we have to fulfill. And so we need it to maintain the stiffness and stability over the time of the procedure. So ideally about an hour, but then will dissolve and degrade over time. And it needs to withstand either high temperature or low temperature, depending on what type of ablation is being used. And it needs to insulate the healthy tissue from the target tissue. And it needs to stay in contact with the tissue, so not succumbing to the effects of gravity like saline or CO2 does. And so with all of these in mind, we took Dr. McBride's initial idea and ran with it, and the students tried all kinds of different situations. And so the main test that we use, we have a video here. So on the left is a foam that is stable over time, and these are a time-lapse video. And on the right is a foam that collapses quickly. And so all we need to do is take a consistent weight in a graduated cylinder, which allows us to measure the height of the foam sample over time. And so the experiment's usually an hour, since that's the target time. And then we can do some more calculations with this. If I go to the next, there we go. Okay. So there's two measurements that get taken. I believe the students pull out like every 30 seconds or every minute over the hour and record this data. And so just use a plastic weight to provide a uniform force to the top of the foam, and then measure the height of the foam at the beginning. So that's 100%. And then the foam will collapse over time. And as it separates back into its original liquid and the air escapes from the foam, then in addition to the height decrease, there's a liquid that you can measure from the bottom as well. So we take those two measurements and then divide or normalize by the original height of the foam to get a percent stability. So what's nice about the lab experiments is that we can control all of the parameters. We can control the variables. So things like temperature, how the foam's made, what kind of equilibration times, what additives we're adding. So we can test those with a lot of different variables and figure out, how to optimize the foam before we inject into pigs or into humans, right? And so we can map out how changing the foam structure will change their properties. And so the students get a nice material science experience out of it. Okay, so like I said, I can't talk about the specific materials that we're using, but we can summarize some of the variables we're at least thinking about. So this is what the data looks like after measuring how much the foam collapses over time. And so 100% would be the original foam heights. And so as the foam collapses, that's decreasing from 100% stability as a function of time. And so like Dr. McBride outlined, the goal is to be around an hour, although worst case scenario, if it's not quite to an hour, he could inject more, right? And then, so that, it doesn't have to be exactly 1 hour, but around there would be great. And of course, we don't want it to last forever either. So there's a sweet spot in there. So the students tried many different variables. And then this case, they were trying different equilibration times. And so they learned that being precise in their steps in their measurements is key for making reproducible foams. And so they were able to optimize this step and then take that going forward for all future foams. And then they started testing different combinations of materials and different methods for foam production. And so what they could see was that they could optimize the stability of the foam to hit that 1 hour mark. And then if you kept measuring it, it would eventually collapse and be absorbed. But ultimately, we identified conditions that were used for porcine or pig trials. And so that was exciting to be able to see the research move forward and see where it's going to go next. And then most of our experiments we've done at room temperature, but obviously the human body, right, is not 20 degrees Celsius. And so we wanted to confirm that changing the temperature wouldn't drastically change the stability of the foam. And what we found, it's a little bit trickier to run experiments at 37 degrees Celsius based on the equipment that we have, but the students were able to test that it doesn't change the foam stability. So what's nice is that we can do the experiments at room temperature and they'll still map onto the results that we expect. That's not quite the same as the foam in contact with actual ablation energy. That's a separate experiment that we're still working on, but this is promising at least for doing initial studies in the lab and then having them translate into either animals or people. And then last but not least, we've been assessing different additives. So we've got a base foam, right? And that is stable and it has the properties that we want. And now we're trying to determine if we can either improve on that to see how much we can push it, or can we add other therapeutic additives that would enable other applications of this foam or enable delivery of beneficial agents in addition to the foam itself, which is a neutral foam background. And so we keep pushing on this and we'll see, that's what current students are working on this semester to see where we can go from here. And then I think based on time, we have a few minutes, Jeremy, if you want to talk about what the in vivo tests you were able to do.
So as she mentioned, we took our best foam and we we're able to do some porcine studies at Mayo Rochester with the help of Tim Nelson, who's oversees the collaborative grants. So here you can see a CAT scan of a pig. On the left side of the screen, you can see a dark ovoid shape. And on the right side, you can see there's no such shape. So on the left side, we injected our foam. It's black because it's low density. You can see there's a nice displacement of the liver there, and it hasn't spread out like we saw in the prior image where we injected the fluid. It's mounded up and it's shown good body there. On the opposite side, you can see a white line going through the ribs there. There we injected some saline. You can't even detect it's there because it's all kind of run downhill and gone to the path of least resistance. So initially we just injected into the different compartments, meaning next to the liver, next to the lung, and next to the kidney, and evaluated with scans every 5 minutes for an hour. And results were very encouraging. Next scan, or next, next slide. They showed that it held up and actually didn't change much at all over that hour. So that was fantastic. Next, we wanted to evaluate how it would stand up in vivo when exposed to microwave energy. You can see a similar image there on the left, but with a microwave probe placed, I think this was about 9 millimeters away from the foam. So we did a typical ablation with the same duration and energy as we would expect, and didn't see significant breakdown of the foam. On the right, you can see a scan that we performed with contrast enhancement. The contrast enhancement, what it does is it increases the density, or in other words, makes the image brighter where there's blood flow. So we can see that same black area where the foam has been injected. Then we can see a dark ovoid area next to it where the ablation took place and the tissue's been ablated or devitalized. So successful in that the foam did not deteriorate rapidly when exposed to microwave energy. Next slide. We did the similar thing with the cryo probe. So in this case, we placed the probe. It's a little different angle, but same idea. Near the edge of the liver, injected some foam next to it, and performed ablation. The foam did not denature rapidly when exposed to the ice. It can be as low as -40 degrees Celsius, actually. And again, similar image on the right after having received contrast dye. Again, you can see the stable foam and the devitalized tissue where the ablation took place. Next slide. We did a few additional studies in the pigs, but what the intent was, again, was to just evaluate stability in vivo and stability in vivo when exposed to the microwave and cryo energies. So the next steps are, as mentioned by Dr. Glogowski, filing for patent and going through that process. I'm working on an IRB for inpatient use. And then, of course, exploring marketability. Is this something that would be generally useful in the medical community and that there'd be interest in other institutions using? Furthermore, we've already started exploring other variations, like what more can we do with this foam as a carrier for new functions, or to use it in new ways, not just for displacement of ablation, but for other techniques. And we have some preliminary studies that we actually did in the pigs with that, and Dr. Glogowski and her students are further working on those new applications and different flavors of foam. All right, I guess for questions then, unless you have something else you wanted to add, Dr. Glogowski.
I just wanted to skip to the end to make sure for the acknowledgements. As Dr. McBride mentioned, Dr. Tim Nelson, has been a major part of not just like the pig studies, right, but the whole collaboration between UWEC and Mayo Clinic Health System Eau Claire. And so His support in enabling this project to continue has been really fantastic. Just to see the research move forward and the potential patient outcomes, but also for my research experience, right? Being able to work collaboratively on a project that uses my background and has direct clinical applications, and then the experience for the students as well. It's been fantastic for the undergraduates to be involved in this research. And then the Material Science and Engineering Center supported this research to get it going as the new collaboration was getting off the ground. And then we've had multiple undergraduates get this project started, plus funding along the way. So thank you to everybody. And then didn't have time to talk too much about future work, but wanted to leave time for questions. So I'll just leave this slide up here, I think.
Great. Thank you to both of you, Dr. and McBride. So just a reminder, if folks have questions, this is the time to ask. We do have one question in the chat by Mike, so maybe I can, I guess, read out that question while others are putting in their questions to the two presenters. So Mike's question is, have you considered using experimental design methodology to hone in on the best combination, that is, of method of foam production, etc.?
I didn't quite catch the last part of the question, Catherine.
Oh, sorry. So it's kind of a long question. So I guess Mike's question is, have you considered using experimental design methodology to hone in on the sweet spot of foam properties, additives, method of foam production, etc.?
Yeah, so that's a good question. When we were starting out, since it was a new project, I just gave the two students, I'm like, just try whatever you want. You know, we're exploring, we're being creative here. And the goal was to see what was the best foam we could come up with? What was the longest it could last? Because like the first couple would only last for a few minutes, right? So the target was an hour. And so once we got it within that range, did we necessarily use like a formal design of experiments kind of thing? No, not so much, because at that point, then we transferred more to thinking about like the in vivo studies and our future studies and adding the additives, which throws off the whole balance of everything again. So I hope that answers Mike's question.
Furthermore, we found some literature that was also evaluating biocompatible or biofoams that gave us some idea of experiments that we may run, some potential additives to use. And then, you know, as far as like production methods, we use some methods that we already employ in interventional radiology or similar things. So we had some rough guidelines that her students explored, but I guess we used the close enough guidelines.
Actually, there is a new question in the chat now. It is from Mary, and it says, do you envision that foam will completely take place of using liquid or gas for displacement? Are there situations that the foam would not be expected to work as well as a liquid or a gas?
Yeah, that's a good question. So I don't think it would fully take the place of it, because when it comes down to it, pulling some saline off the shelf and injecting that can work well. Really, it comes down to sometimes the body compartment we're injecting in what's called the retroperitoneum, where the kidney tends to be more confined space. So if we inject fluid there, it's more likely to stay put. Interestingly enough, when we injected the foam into the chest adjacent to the lung in what's called the pleural space, the foam pretty much dissipated immediately. Probably because there is what's called surfactant or a natural type of detergent that is produced by the lung in that space, which I hypothesized helped denature that foam. It could also be due to the differences in positive and negative pressure with respiration, but for whatever reason, it didn't hold up in the chest cavity. And that could be interesting side, experiments potentially. So air will probably still be used there and fluid. I think the place where this will be most helpful is in the liver, because the body cavity and what's called the perineal space, where the bowel, the liver, the spleen, and a lot of those large organs rest, is a larger space. And that's where injecting fluid, it tends to run away from where we inject it. So for this indication, I anticipate it'd be most helpful next to the liver, and would probably be used in circumstances where someone has, injected some fluid, or they just realize, hey, this is going to be a bad place for fluid. So it'll have its indication potentially, but not completely replace other techniques that are established.
Great, thank you. Another question. What is the timeline for human use? Do you have an estimate?
Depends on what the IRB thinks of our idea. As we mentioned, kind of one of the main parts of the premise of doing this is having it be readily transferable into humans, right? We're using reagents or materials that are used every day in the hospital and that are innocuous. So the individual components of this foam we use all the time, and they're known to cause no problems. So if we can present a compelling case to the IRB that this would not put patients at harm and be increased risk, then I suspect that they would let us move forward with it. So as far as the timeline, hard to say, but potentially next year.
Wow, great. That's exciting. I wonder if either one of you maybe comments on your experience involving students in this type of project. It is obviously a very cutting edge, very exciting, very new kinds of projects. And, depending on, do you require students having experience before joining this project? And what is your overall experience in involving students in projects that have such potentially huge impacts on and clinically and otherwise?
Yeah, I'm happy to answer that first, and then Jeremy, maybe you can add to that if you want to. So as the faculty mentor, right, I oversee the students directly here on campus, and it's been, like I said, it's really fantastic actually having the students involved, right? Because students from first years to seniors have been involved in this project, but because they're undergraduates and they, don't have years or decades of experience that has maybe focused their attention, they bring their creativity and problem solving skills and are able to think outside the box sometimes and solve some of the problems. So actually that's been really great. And the fact that I've been able to hire a couple of students and they get to work together and brainstorm together has been really helpful. And then one of the funding sources has been through the new Biomedical Innovators funding, which brings in first year students. And so the students, well, now they're second year students, Kira and Marshall. And so now they're sophomores, but they started basically day one as freshmen on this project and got up to speed quickly and really immersed themselves into learning everything. And now they're the senior students on it and are onboarding a new student. And so I know the students have said they really appreciated being able to work with Dr. McBride and seeing his process and understanding his motivation for doing this project and really tying it directly to working with patients and improving their outcomes.
I think the undergraduate involvement's great. Initially I was just looking for some funding, right? Some resources in order to move this forward. But the fact that there's undergraduates involved in the collaboration, I think is fantastic. And that's, one of the best parts of this. I started doing cancer research as an undergraduate, and that kind of set me down a path for my future. And I think experiences like this can be formative for people. And so I appreciate that there's curious and committed undergraduates who want to be involved. And Dr. Glogowski's done a fantastic job working with them and mentoring them on a day-to-day basis.
Great, this is awesome. Any other questions from the attendees? Don't be shy. Well, you can unmute yourself, I guess. And actually, since this slide is up about future work, does any one of you want to maybe make some comments on your future directions or future work?
So I'll let her comment on the thermochromic material, what they're doing in the lab. As far as other applications, we're looking at, is this foam something, if we use carbon dioxide as the gas to make it, is this something that we could potentially use for other applications and be injectable into blood vessels? Carbon dioxide is rapidly absorbed in the bloodstream. It doesn't cause problems, opposed to room air that has nitrogen that does not absorb rapidly. So there's potentially some interesting applications that we could use with the foam made with carbon dioxide that was stable enough to inject and then could carry other functional additives. So we've started looking into that with preliminary research. She's working on that with her students, but she's also doing some interesting studies as well with the thermochromic materials and insulation. I'll let her comment on.
Yeah, so we went through the requirements for the foam, right? And Dr. McBride mentioned the different types of ablation, right? One heats the tissue, one cools the tissue, but ultimately the foam needs to be insulative, needs to insulate the healthy tissue, right? And so we determined that we could test this by creating what's called a tissue mimic. And so using a hydrogel that has the mechanical properties and other properties of tissue, because it's mostly water plus a little bit of polymer, you can mimic the behavior of tissue without actually injecting it into another pig or into a person. And what we can do with this tissue mimic is also embed a thermochromic dye. So these dyes change color when the gel changes temperature. And so if the temperature of the tissue gets too hot, that's when there's that nerve damage and the patient experiences pain. So we're trying to monitor how hot does the neighboring tissue get when exposed to the ablative energy. And so the students prepared these tissue mimics with embedded thermochromic dyes. And right at the end of the summer, we were able to actually apply the ablation with the probes and capture the colors. And so there's a lot of data analysis going on now to translate the colors into the temperatures to make sure that the foam is actually insulating the healthy tissue, the tissue mimic, to make sure that it's insulative as predicted.
Great. Any last question? We have 1 minute left in our official time together. If not, I'd like to thank our two speakers. It is really wonderful to hear from both of you, Dr. Glogowski and McBride. Just as a reminder, next week there will be no forum, but we will resume the faculty's academic staff forum on October 20th, where we will be meeting in person in the Cedar Lounge. See everybody there, and thank you again to our two speakers.